This is because the contrast will be flowing through the carotid and the internal jugular vein, and this helps in appreciating the bone in between these vessels, which is getting eroded in a better manner. Okay, so that is the importance of the Phelps sign, and here you can see how the bone is eroded by the glomus tumor. Okay, between the carotid and the internal jugular vein, you have the bone getting eroded. That is what is known as the Phelps sign. Okay, now this is a picture where you can see how the glomus tumor can grow and invade the multiple cranial nerves in that area. Now, true about glomus jugular tumoritis. This is one question which was asked in PGI. More common in males. It is wrong, right? It is seen more commonly in females at the ratio of 5:1. Arises from non-chromaffin cells. Yes, that is true. Okay, only very rarely it can arise from the chromaffin cells. Lymph node mets are seen. No, lymph node mets are not seen. It is a benign tumor, right? It is multicentric, that's true. Fluctuated tinnitus and conductive hearing loss is seen. That is also true. So the true statements are B, D and E. Okay, B, D and E are the true statements. Now, what are the other investigations that can be done? You can do an MRI. Okay, when you do an MRI, what are the things that you can look for? MRI will show a salt and pepper appearance. Salt and pepper appearance because of the phlovoids. Okay, or you can do an MR venogram and an MR arteriogram also may be done to show if there is any decrease in flow through the carotid because of the tumor compressing. Okay, so these are the various investigations that are done for a case of a glomus tumor. So this is the picture which shows the phlovoids, and here you can see the salt and pepper appearance. This is how you do an embolization. Embolization is, this is a picture of salt and pepper appearance, and here you can see the embolization which is done preoperatively in some conditions where you will need to decrease the size of tumor before the surgery. Okay, and yes, you have to do a digital subtraction angiography before going for a embolization. Okay, so these are the various investigations that are done before planning surgery for the patient. But before all that, you will have to stage the tumor, right? What are the various stages of glomus tumor? The staging is done by Fish classification, and according to type A, the tumor is confined to the middle cleft. The tumor is confined to the middle cleft. In type B, it goes on to involve the mastoid. Okay, goes on to involve the mastoid, but there is no involvement of infralabyrinthine compartment. Okay, so this is the type A, which is completely confined to the middle cleft. In type B, as you can see here, it is going into the mastoid. The facial nerve is very nearby. And type C, it goes into the infralabyrinthine area. Okay, type B, only the mastoid and tympanum, that is the tympanomastoid area, and there is no infralabyrinthine extension. The type C can be divided into C1, C2 and C3 depending upon the involvement of the carotid artery. Okay, the vertical part of the carotid artery will be involved first. If it is limited involvement, it is C1. If it is extensive involvement, it is C2, and when the horizontal part of the carotid is involved, that is C3. Okay, so that is how it is getting divided: C1, C2 and finally C3. This is the internal jugular vein. The sigmoid sinus going to form the jugular bulb over here and forms the jugular vein. Here you have the carotid artery going. Okay, this is the vertical part of the carotid, then it forms the horizontal part here. Okay, this is C1 when only the limited part is involved. C2 more than that is involved. C3 there is extensive involvement. Okay. Okay, in type B only the tympanomastoid area is getting involved, there is no infralabyrinthine extension. In D1 what is happening? There is intracranial extension, but it is less than 2 centimeter. D2 it is more than 2 centimeter. The extension is more than 2 centimeter. Now, what are the treatment options for a patient with a glomus tumor? If he is an elderly patient and it is a very small tumor, you can actually just follow up the patient. There is no need of going for surgery straight away. Okay, and if it is a fish type A tumor, you can go for transmeatal approach because it can be accessed by just elevating the tympanomeatal flap. Okay, if it is type B tumor, you will have to go for transmeatal along with an extended facial recess approach. Now, how do you differentiate a facial recess approach from an extended facial recess approach? In extended facial recess approach, you are sacrificing the chorda tympani nerve to increase the space for approach. Okay, the corridor has to be widened. For that, you are sacrificing the chorda tympani nerve, and that is what is known as the extended facial recess approach. And in type C tumors, what you do is you go for fish approaches, fish infratemporal fossa approach is done for type C tumor. Okay, type C tumor, you have to do a fish infratemporal fossa approach. Now, if the tumor is large, as in type C or type B, you can actually go for a preoperative embolization. Now, what is being embolized? It is the ascending pharyngeal artery that is embolized. Ascending pharyngeal artery is the artery which is supplying the glomus tumor. Okay, the internal jugular vein is being supplied by the ascending pharyngeal artery and it becomes the feeder for the glomus tumor, and hence if you are actually going to embolize this ascending pharyngeal artery, how is this embolization done? For that you use polyvinyl alcohol or PVA material. That is the one which is most commonly used, and with that, when you are doing an embolization, the risk of bleeding due to the tumor will be reduced and the size of the tumor also can be reduced. Okay, now what else can be done? For tumors which are less than 3 centimeter, you can actually go for another approach. What is that? It is gamma knife radiotherapy. Gamma knife radiotherapy is a kind of localized radiotherapy which helps in arresting the tumor growth. It won't bring down the tumor size, but it can arrest the further growth of the tumor, because if the tumor grows further more than 3 centimeter, when it goes, it can go and invade the adjacent cranial nerves and can cause problems. To prevent that, you can go for this stereotactic radiotherapy. Okay, and it is very effective, especially in elderly, where you need not go for the risk of the surgery. And in elderly, there is another option. If the tumor is more than 3 centimeter, you can go for radiotherapy. Radiotherapy also helps in reducing the size of the tumor. Okay, so these are the various options which can be used for dealing with the glomus tumor. So today we have learned about glomus tumor, which are of two types. Can be either glomus tympanicum or the glomus jugulare, depending upon where it is arising from, whether it is coming from the jugular bulb or from the tympanic plexus over the promontory. And we have learned that there is a 5:1 ratio occurrence of it in females, and this glomus tumor, it is actually arising from non-chromaffin staining paragangliomas. Okay, they are actually non-chromaffin staining paragangliomas, and these tumors, they are having a peculiar cell balance pattern in histology. But do you do a biopsy to prove this diagnosis? No, you never do a biopsy, because the biopsy can cause a lot of bleeding. Instead of doing the biopsy, we go for the proper clinical examination and we look for the various signs like the brown sign, equinox sign, rising sun sign, or the red reflex. Okay, all these things you look for, and you do a CCT to look for the Phelps sign, and MRI to look for the salt and pepper appearance. Okay, so once you confirm the diagnosis, you stage the tumor, whether it is stage A where it is completely confined to the midlear cleft. In type B, it is going into the mastoid, tympanomastoid area, but there is no infralabyrinthine extension. In type C, there is infralabyrinthine extension, where in C1 it is having limited involvement of the vertical part of the carotid. C2, there is an extensive involvement of vertical part of carotid, and C3, there is horizontal part of carotid being involved. In D1 and D2, there is intracranial extension, which is less than 2 cm and more than 2 cm respectively. And the treatment of glomus tumor is most commonly when it is small, and in an elderly patient you can actually wait and watch and keep the patient under proper follow-up to look for the tumor's growth, because it is a very slow growing tumor like the vestibular schwannoma. Another thing that you can do is you can go for a stereotactic radiotherapy, especially when it is less than 3 cm in elderly. Then you can go for the various surgical options, especially in young patients. If it is confined to the midlear, you can go for a transmeatal approach. If it is going into the tympanomastoid area, you will have to go for a extended facial resource approach. And if it is having extension into the carotid, then you will have to go for the fish infratemporal fossa approach. Okay, and you can also give radiotherapy in the elderly. Before surgery, you can go for a preoperative embolization to decrease the risk of bleeding and also cause the shrinkage of the size of the tumor. Okay, these are the various things that you have to know in a nutshell about glomus tumor. A short topic but a high yielding topic. So please go and read today itself. Goodbye.